Good morning, everyone. Welcome to the second episode of Sunday Servings. My name is Dr. Vishal Chabra. I am the organizing chairperson for this Sunday Serving series, which we have started last year in November as part of the DPS academic activities. We're planning to do this one academic event on Zoom every month. So this month and the starting of this year, we're starting with Dr. Sandip Deshpande. Sandip has been my close friend for many years now, and he has studied in UK, returned back, and besides practicing general psychiatry, adult psychiatry, he is also very much focused on psychosexual health, and he's going to talk about sexual medicine. We have two chairpersons for today's meeting. Dinesh Kataria sir, he is professor in HOD, LHMC in Delhi. For people who don't know, Lady Harding Medical College in Delhi. That's for people who are outside Delhi. And we have also Dr. Pankaj Verma, professor in HOD, another big institute, BMMC. I always keep confusing. I say Safdarjung Hospital.
Namaskar. Thank you.
So
it's one and the same, but
yeah.
Vardhaman Mahavir Medical College.
Yes. Vardhaman Mahavir, yes. I keep forgetting the first name. Vardhaman Mahavir Medical College, yes. So VMMC and LHMC, two major institutions. Their HODs are there presenting DPS, and I'm very honored they are there. Just two more lines. The plan of today's event is, if I discussed with Sandip, and Sandip was very interested in doing a course on psychosexual medicine. Because it's something which is not really focused on in our postgraduate career and studies. So after this event, today's event, and I'll be obviously uploading it on YouTube. People who are interested, Sandeep will be providing details, and we can restart a certificate course free of cost for the members of DPS. Makes an incentive to become a DPS member, all those PGs and SRs. And early career psychiatrist, and we will be giving a certificate, co-branding of DPS with Allo Health, where Sandeep is. Okay, over to our chairperson Dinesh sir and Pankaj Verma sir.
Thank you, Dr. Vishal. Am I audible?
Yes, sir.
Yes, sir.
Thank you, Dr. Vishal, and my co-chairperson, Dr. Pankaj Verma.
Sir.
You know that this topic is very important in the present context, because you know that we usually don't talk about sexual health, so sexual medicine will come later on. So and ultimately, you know, now this spiritual health, physical health, mental health, so I believe that this is the high and right time that one should, or we should talk about sexual health, and later on then to sexual medicine also. So if you just let us talk about it. Say, India is a capital hub for the diabetes, hypertension, and all that. And I've seen that most of the people, those who are on anti-hypertensive medicine, they are either on some metoprolol or bisoprolol or something or the other. Similarly, diuretics are there, and then anti-diabetic medicines are there for diabetes and all that, right? So it affects, or other things also affect. And most of our medicine in psychiatry also, they put an effect on the sexual health. And because of the cultural issues and all, say we don't discuss it directly, even indirectly also. And even the patients, they do not come out openly. So I think this is the right platform, and this is going to be in a very good positive direction when we will discuss about that this thing, when Dr. Sandip Deshpande will be discussing about this thing. So students will be definitely, and the members will be definitely benefited by this thing. And this is the need of the hour, which actually we are not talking about openly and otherwise. And we should ask, and how do we ask, and how to interpret the answers, and how to encourage them to respond what we ask. So I think all these things will be covered by Dr. Sandip Deshpande in this sort of, deliberations. So over to Dr. Pankaj Verma. Thank you.
Thank you, sir. Thank you. Yeah, as sir said, this is something which we need to discuss. I can share you my experience as a PG. We never used to even touch this topic, which was a big no-no in Varanasi. So my first experience when I came to Delhi only at RML. I had a first-hand experience, and I thought, oh, this is something which we were missing during our training. And in Delhi, I think RML and Safdarjung both are running their psychosexual clinic for almost 30 years now. And still, there are so much to be done, so much to learn. Because I have seen people saying there were certain nursing staff or paramedical staff which used to say, why are you running this clinic? You are just providing alprazolam and making them sleep rather than treating them. From there, now what we are doing, I think for a few years back, we had a full-fledged conference on this. So still, so much needs to be done. And there are things which needs to be addressed. I think today's talk by Dr. Sandip will help us focusing more towards how to improve this area of psychiatry. So over to you, Dr. Sandip.
Thank you very much, Dr. Verma and Dr. Kataria. That was indeed sagely advised to set the scene when it comes to the importance of psychosexual medicine and what young early career psychiatrists and postgraduates in the mental health field can learn. Dr. Vishal, are you able to see the screen?
Yes, 100%. That's all good.
Okay. And as we discussed, I'll make a presentation. If there are any questions, please populate the chat window. We have already had a few questions there. When Dr. Verma was speaking about his postgraduation days, I remembered mine. So I used to literally eat my HOD's head, Professor Sharma, and say, why don't we have training or teaching in this specialty? And that interest which got kindled, I carried it forward when I went to UK, and I was fortunate because in the equivalent of SR-ship is the higher specialist training. So that's a 3-year training. And we are given 1 day off to go away and do whatever we would like. Just requesting.
Just a minute. Yeah, please keep your mic on mute mode, please. Everybody.
Thank you, sir. Thank you, sir. So in the UK, higher specialist trainees are given a day off, a little bit of funding to go and do any course of interest of theirs. So my batchmates, some of them did filmmaking, somebody did medical ethics, someone did an MBA. Since I was interested in this, I did a postgraduate diploma in sexual medicine. Just a quick expression of any conflicts and interests. I am the medical lead for this startup called Allo Health. While I don't currently have any stakes in the company, but I'm responsible for training. I'm a clinician on that platform. And a bigger conflict of interest is I'm very passionate about this specialty, and I believe everybody in the mental health field can and should pick up some skills around this. Okay. While the title says for postgraduates and early career psychiatrists. Vishal did tell me that there will be senior clinicians, there will be other DPS members. So I'm hoping to cover for everybody, but apologies if it sounds too elementary. I'll introduce you to the field of sexual medicine, touch upon history taking, diagnosis and classification, approaches to common sexual dysfunction, how to assess, as was mentioned by Dr. Kataria, and finally end with sexual medicine as a career or specialization. There have been some questions already in the chat about what courses there are and how could one train further. So I'll try to do justice to that. And after this, we'll have some time for Q&A, I hope. Okay, so I've picked these from some online consultations. I'm not going to name the doctor. I've tried to hide their identity. But yeah, this is somebody from the Ayush background. He's trying to answer, he or she, you don't know, a question on the effect of masturbation on health. I mean, pick any line and at least it horrifies me. I mean, I'm looking at the line which says, every time semen is wasted, masculinity, energy, and life decreases. It is simple mathematics, etc., etc. If you look at the last line, 9 people found this answer helpful. So, you know, I really wonder what this is okay. But the last line is what gets me worried. Apply coconut oil on the penis twice a day. So I don't blame the fraternity, the doctors, because there is no structured training for medical professionals, even to answer simple things like these. So I'm hoping that by the end of this talk, or people who are interested and take it further, will never give answers like these. So psychosexual medicine, my own hypothesis is that it's a marriage of specialities. There is a lot of psychology, certainly mental health and psychiatry overlap, and other specialities of medicine do come there, notably obstetrics and gynecology, endocrinology, urology, skin and venereal diseases. But as I was mentioning before we started this talk, we are at the forefront, mental health professionals. If we don't take up the mantle, unfortunately, we'll end up noticing many other people who would end up in this specialty. So your competitor for this specialty is also the chola chap doctor, or the guy who puts a tent and says he sells Himalayan herbs, or a lot many qualified quacks, as I call them, who practice with treatments that don't have a robust clinical evidence. So my talk is more clinically oriented. I'm more than happy to guide you with papers or information after this, if you do have any questions. Sexual medicine, when I started training over 10 years ago, I thought it'll be a small niche area. I'll quickly master it. But little did I know that it's a wide specialty in itself. This is just to highlight on Wikipedia, you have about 50 odd journals, and it's growing. I'm hoping to introduce to you some very quick basics of sexual medicine. These may sound unconnected, but please bear with me, because when we talk about some cases later, you will see how this information comes together. So common scenarios, people will come and ask you questions around anatomy, having a small penis. They will ask you about what medicines they can take to make intercourse less painful, increasingly women asking this question. Then men have hordes of questions on masturbation, concerns about it. And I don't need to tell you about Dhat syndrome, which is a culture-bound syndrome in the Indian subcontinent. Then you get these scenarios where newly married couples come, they complain of problems either soon after marriage, concerns around whether the man is impotent. If a man is not able to perform, the woman typically has 3-4 hypotheses. Either he is important, or he doesn't like me anymore, doesn't find me attractive, he's having an affair, or I think my husband is homosexual, he never told me that. So a variety of scenarios and presentations can come across. The basic purpose of sex, if you get interested in this specialty, read anything and everything that you can by these two names, American sexologists called Medza and McCarthy. They write wonderfully, very easy to understand and read. So procreation, recreation, and relational. These are the 3 reasons why people have sex. I haven't yet defined what is sex according to my definition, but just go with the idea that the need to start a family, have children is procreation, recreation and relaxation, to have fun, relational. So what do I mean by relational? Good relationships and good sexual relationship, they go hand in hand. Men from Mars, Women from Venus. I think you are familiar with that book title. It's a very catchy book title. Not all of it seems to be, accurate, but women, by and large, tend to follow this curve from left to right. So if women are having a good relationship, they feel secure, intimacy seems like a natural extension. On the other hand, men tend to follow the curve from right to left. I didn't say all men or all women, so don't misquote me. By being intimate and sexually active, men are able to show how much they care or they love their partner. So my definition of sex is on a spectrum. Only one end of the spectrum is intercourse or the penetrative sex. For convenience, I've added the label outer course. Intercourse, outer course. Outer course is anything a couple does behind closed doors without clothes. This is not a peck on the cheek, or it is not something that one would do in a public space, but anything that a couple would do that involves an extended degree of intimacy. So penetrative sex is not equal to sex. A very important concept for you to know, because this comes in handy when you counsel your patients later. So human sexual response is a complex event. It requires a good endocrine function, vascular supply, neurological functioning, a willing partner, and of course, a willing mind. So problems in any of the above areas will lead to sexual dysfunction. I practice in Bangalore, the IT hub of the country. So for the folks here, I say software and hardware. So the top 3 are hardware and the bottom 2 are software, and people get it quickly. So men and women require only 3 things for a good sexual functioning when it comes to hardware: blood supply, nerve supply, and sex hormones. So if you're needing to evaluate, you only look at common causes there. As Dinesh sir was saying earlier, conditions like diabetes, hypertension, they tend to affect the neurovascular functioning. Okay. If there's one takeaway from today's talk, it should be the acronym DOR, because this is the basis of everything we do in sexual medicine, whether it is classification, treatments, history taking. So this is an evolved sexual response cycle. Originally, it was postulated by Marston and Johnson, who you have probably heard of. There are many variations that have gone through. So I'll spend a couple of minutes on this. I actually show this to my patients in consultation, or I write desire, arousal, and orgasm on paper and scribble, and that makes it easier to convey a few things as well as to educate them. So it all starts with desire, which is in the mind. So desire is of two types. D1 is spontaneous desire, wherein the person, the brain just lights up and they say, okay, I feel I want to get intimate. D1 tends to be high in the honeymoon period, and honeymoon period has been defined by some researchers, and it is thought to exist for about 1 to 2 years in a newly constructed relationship, in a newly married couple. So 1 to 2 years, D1 tends to be high in both, the partners. For the sake of discussion, I'm referring to heterosexual couples here whenever I say a couple, but it is no different to same-sex couples as well. D2, on the other hand, is reactive desire. So one partner has the desire, the other partner joins in or has the desire that gets kicked in. Okay. Excitement in men is erection, and in women, it is rush of blood into the genitals. So rush of blood into the vagina, rush of blood into the breasts, the nipples getting erect. Lubrication in women is a feature of excitement. In men, we ask 3 questions when it comes to erection. Early morning erections, which are actually not sexual erections, but they are erections as a result of testosterone being high between 4 a.m. to 11 a.m. Erections during masturbation, if they do engage in it. And thirdly, erections when they are with a partner. Moving on to orgasm or climax. In men, climax is ejaculation. There are 2 processes that happen here. The physical act of the semen coming out and a sensation of pleasure and joy, a spike of it, which lasts for about half a minute or so. And more often than not, the 2 things coincide in men. Typically, men are able to last 2 to 5 minutes during the penetrative act. They ejaculate within 2 to 5 minutes, which is the global average. Climax in women is characterized by, again, a spurt of excitement, a sensation of joy, the whole body going into a tension and relaxation. Women are luckier than men, because they can attain orgasm in multiple ways. Vaginal orgasm is only possible in a third of ladies. That has nothing to do with the man's size of the penis, how long he is able to have intercourse, how deep, etc. It is just that only a third of ladies are able to experience it. Large majority can experience orgasm through clitoral orgasm, stimulation of the clitoris, or through various other erogenic spots in the body. After climax, there is a rest stage. So men are not able to get an erection immediately. It may take them a few minutes to a few hours. With advancing age in settled relationship, it may take up to a day for the man to be ready again. Women are again lucky because they don't have a resolution period. They may feel excitement or get excited one after the other, if they wish. So the point of knowing this, and it solves a lot of the queries that come from your patients. I'll just illustrate an example here. Let's say we have a young man who has premature ejaculation. So he ejaculates under 2 minutes all the time, most of the time. Now, because of problems in the O stage, he will have or he may have difficulties getting an erection. Over a period of time, not getting a decent erection, he will lose his desire. So you see that this leads to this and this leads to this. I'm moving my cursor in the hope you can see that. So think of his partner, the lady. If this man loses his desire, she keeps trying perhaps, and over a period of time, she becomes a D2. She also, stops trying. Or take the case of a lady who has pain during intercourse. Let's say all her physical causes are ruled out and she has vaginismus, which is a phobia. We'll talk more about it later. So because of problems here, she may not comfortably relax. So she complains of dryness in the vagina. And what was supposed to be fun, if it ends up becoming painful, she loses her desire. And he tries and he gives up as well. So this comes in handy quite a lot. Okay, classification of sexual dysfunction. You're still with DEO. Whether it is the new ICD-11 or the DSM-5, they broadly follow the same classification. Desire disorders, so it's called hypoactive sexual desire disorder, HSDD, in both men and women. Excessive interest, I think this is more for MCQs rather than seeing it in clinical practice. Yeah, I remember as MBBS students, we all wanted the nymphomania and satyriasis as a condition. But in reality, at least in the decade or more, I've not seen too many cases, I'll say. Excitement, erectile dysfunction, inability to get aroused. This condition in women is called FSAD, female sexual arousal disorder. Orgasm, you have premature ejaculation in men. Delayed or retarded ejaculation is another condition. Anejaculation is where a man has never ejaculated, either during masturbation or nocturnal emission, wet dreams. So that would be called as anejaculation. Typically, those cases go to a urologist because they, more often than not, have a hardware problem. Other conditions, dyspareunia is a general term for any pain during sex. Vaginismus is a common one. So since the title of this talk is Common Sexual Dysfunctions, I'll cover erectile dysfunction, ED, premature ejaculation, PE, and vaginismus, and a few other references to other conditions. So what is a dysfunction, or when is it a dysfunction? You're all probably familiar with these terminologies. I won't spend much time, but if someone comes and says, I've tried once, I was not able to get a good erection, I think I have ED. Well, no, you need recurrent appearance of the problem causing distress, interpersonal difficulties. You rule out other conditions, comorbid. You also want to know if it is primary or secondary, lifelong or acquired. Is it situational or generalized? Situational is with a certain type of stimulation, with a certain partner. Generalized is across the board all the time. Okay. So I'm still with the basics, unrelated, but they'll all come together. Performance anxiety cycle. Two colleagues of mine in the UK, Andrew Yates and Ross Ottery, they came up with this concept. So initial failure, let's take the same guy who came and said he tried and he could not get an erection. So immediately he starts getting doubts and worries. Often you notice spectatoring. Spectatoring is a technical term introduced by Masters and Johnson. It is almost like watching oneself, because in the act of intimacy, there are 4 arrows. The act of he giving pleasure to her, she accepting it, she reciprocating, and he enjoying it. So there is disruption when there are doubts and worries. So he starts watching his own self. I mean, I sometimes jokingly say he becomes the mechanical engineer, where he observes how much of an erection he's got, what angle. Yes, I've had people say that also. Then he keeps watching his partner, looks at her face, wants to know whether she's excited or not. Then there is a disconnection between the mind and body, software and hardware disconnection. A repeat failure a few times is enough for the person to go into anxiety and to go into avoidance. So showing somebody this slide or explaining to them that something like this happens helps and makes your job easier. There is a concept called as the dual control model, brakes and accelerators, or exciting factors and inhibiting factors. Useful to recognize what they are when you see an index patient. It's almost like a weighing scale. If you have exciting factors that are a lot more, then there are no problems. If there are inhibiting factors which are taking precedence and having more weightage, you can expect a problem. So just to cite some examples, in inhibiting factors, it could be the person's personality if they are shy. It could be their self-esteem issues. It could be interpersonal problems that the partners have. It could be conditions like depression, anxiety. It could be the inability to have enough privacy. So a whole host of biopsychosocial conditions that you can think of. Okay. Alfred Kinsey is a name you should all know. 1950s America, not enough data about human sexuality. He was not a medical doctor actually, but he went on to do a huge epidemiological study, collated data, and it then became a bestseller in America. So he interviewed, I think, about 16,000 people. One of his contributions becomes relevant today, which is called as the Kinsey scale, which helps you again in some basic counseling that you do. So essentially, this one talks about the sexual orientation. Who am I attracted to sexually? So what Kinsey says is sexual orientation is fluid and dynamic, especially in the early formative stages. So people, when they have reached the post exploration, once they are comfortable with their own sexuality, they either take positions to one extreme or the other, either homosexual or heterosexual. Bisexual people are in the middle and varying degrees of it. Bisexual doesn't mean that they are constantly on the lookout for a person of a different gender. When they are comfortable, they don't necessarily want to seek out a person of the other gender. How does this help in practical terms? Okay, I'll give you an example of somebody I met recently. This is a person who was in a hostel when he was in his high school and pre-university. And in a boys' hostel, there was a lot of show me, touch me, and engaging in mutual masturbation with other boys, etc. In his head, he concluded that he was homosexual. Later on, he withheld himself from any opportunities to mingle with a person of the opposite gender. He was quite hesitant to let his family see an alliance and get married, because in his head, even though he was, attracted to girls and women, the whole experience of his hostel would pull him down. So introducing him to a Kinsey scale, telling him that those were early exploratory, more out of curiosity, does not mean that you necessarily have to become, conclusive in your thinking that you are homosexual, went a long way in solving problems for him. Or take the case of somebody who was actually homosexual, was very comfortable with men, but for the sake of his family, chooses to get married to a lady, has no desire or interest in the intimacy domain. A year passes, the marriage is still unconsummated. Forget consummation. Okay, I should define. Consummation is a legal term, not a medical term. Consummation is when, if sexual intercourse has happened successfully at least once. So turns out that the girl's family, get very desperate. And when they came to me and I spoke to them and spoke to them separately, he was clearly homosexual. And the position statement from the Indian Psychiatric Society, there is no treatment for people, who are homosexual. There is no conversion therapy that works or that should be tried. So Kinsey scale comes to your rescue there. Okay, so we are changing gear. So far, I introduced you to a few basic concepts. I explained to you about how different things come to your rescue in your understanding, and some explanation that you give. So we'll move on to talking about how to assess psychosexual dysfunctions. How do you ask? What do you ask? Gladly, I'm talking to a bunch of mental health professionals. My job becomes a lot easier because most of what I'm going to say is probably known to you through what you do as a psychiatrist. Some tweaking definitely needs to be done because there are some sensitivities. So it's a little bit of being a detective, which you would be if you are a psychiatrist, when you're trying to dig in and find out, what caused the panic attack or what are the contributing factors for the depression. You'll have a lot of fun doing that as a sexologist. The broad headings are the same, but emphasis is definitely on confidentiality, use of language. You take detailed history, you do focused examination. Formulation becomes extremely important. Formulation is a marriage between what the story your patient has told you. You're the clever one in the room, so your understanding, your training, you marry the two and give it back to the patient in an understandable fashion. Working diagnosis definitely required. Investigations and treatment as you would do in any other specialty. Anyone wants to type what this is while I take a sip of water? Or you want to unmute yourself and tell me?
Devil is in the detail. Devil is in the detail.
Yeah, somebody said it is Devi Lal karke. No, it's not Devi Lal.
Devi Lal.
Yes, the devil is certainly in the detail. Very important that you focus on getting to the nitty-gritties and the bottom of the problem. Unless, this is how I sometimes say, unless I catch the devil, I'll not be able to help you. So it is best I get into some details. Dr. Kataria alluded to this cartoon, sometimes as a clinician, I am hoping that he brings it up. I don't want to ask. It's a can of worms. The patients are only waiting to talk about it. See, 10 years back when I came back from UK, one of my, how do I say, inhibitions or hypothesis was maybe the Indian patient is not ready to talk. And how wrong I was. The new trend is women, and I welcome this, women bringing their partners, women taking appointments, women coming forth and saying, I need help. I'm not able to reach climax. I need, a consultation on behalf of my partner. So you will not have difficulties. All you need to do is to feel comfortable firstly, and to say that this is something that you practice. So seeing a couple versus seeing an individual, there are two schools of thoughts. There are some advantages, there are some disadvantages. What do I mean? Let's say Jack and Jill. So they come to you, you see Jill separately, you see Jack separately, and then you continue the work with Jack and Jill. There's another level of intervention which Masters and Johnson used to do. Now that is called as conjoint couple therapy, where, let's say, Masters used to see Jack separately and then Jill separately. Johnson used to see them separately, and then all four of them would do conjoint couple therapy. Expensive, requires a lot of time, but nonetheless, this is one model of working. The other is you don't have a choice. Jill has come to you. You say, okay, I've got what I need from you, Jill. Why don't you send Jack? I want to talk to him as well. And then you talk to Jack and Jill. Couples sex therapy, couples sexual consultations, or consultations involving couples, they are found to yield far better results than intervening alone. But sometimes you don't have a choice, so you just go ahead and treat the individual. Advantages of seeing somebody individually: you get history around things like domestic violence, substance use, intent to leave the relationship. I've had cases where she has come and said, "Doctor, please don't tell my husband. I actually like a colleague of mine, and I'm madly in love with that person. He is married, my colleague. I'm married as well, and I wish to maintain both of these relationships." Now, it's an ethical dilemma. What do you do? We can discuss that if we have the time. But you get to know how much intent there is. Infidelity. Then things like the guy who said he's homosexual and he wants some magic to happen and maintain the marital relationship as well. So these things come out when you see them individually. These are also a problem because what do you do with secrets? Short and quick answer to you. When I see them separately, I tell them, I don't hold secrets. But you do end up, getting these disclosures made to you. So you'll have to find clever ways to wriggle out. For example, in the man who said he's homosexual, I encourage him to talk to the family. I will not break this news to them. The lady who said that she is having an affair, yes, we gave her the option of seeing another therapist to clear her mind and her head, to choose between which one she would like to maintain, and then come back for couple counseling. So some very basic tips on interviewing, which are similar to what you do, but remember, people have not discussed, patients have not discussed these issues with anybody. So they are trusting you with some very intimate details. So start with kind and easy questions, less confronting issues, put them at ease, leave the difficult bits to the end. An example there could be, let's say, sexual abuse, for somebody who is having apprehensions about any intimacy. You wouldn't want to ask them straight away, wait for an appropriate time in the session or maybe in the next session. Try not to assume that people know what they mean. Often they use words like, I have problems with erection, when they actually may have had issues with ejaculation. They may say, I don't have enough strength. So don't always assume strength means erections. So it is useful to clarify and use common everyday language. It is okay to use patient's vocabulary, but there have to be some limits. If the patient is using the F word, you need not continue to use that. You may want to educate them and say, let's call this as sambhog. That's a word that is prevalent in many Indian languages. Or you may want to show them some line diagrams and charts and say, okay, this is penis, this is the tip of the penis. Here's the picture of the female genitalia. Try to use simple terms. Yes, you are the one with all the degrees and the experience. You can easily say intravaginal ejaculatory latency time. Did I say it right? Yes, IVELT, which means how long does a man last after penetration. So use a simple term like how long does it take for you to ejaculate or to come or for the semen to come out. So some basic tips there. Use general terms, use some ways to put your patient at ease. An example could be, it is quite common for people with diabetes to have sexual problems. Do let me know if you have issues with your erection or ejaculation. Or let's say if you are the prescribing doctor, you have given some antidepressants, you can ask them or tell them that some people who take this medication can have issues with delayed ejaculation for SSRIs, for example. If you do notice, do let me know. I'm happy to discuss about it, etc. A lot of young men come to me. Sorry, this is an example of an opening statement. If a guy comes and says he's worried about masturbation, you can say, generalize the statement by saying a lot of young men come to me with concerns about masturbation. I'm happy to answer your concerns or questions. We have designed sexual history taking pro forma. I request Dr. Vishal to post it on the Zoom link if that is possible, or Dr. Vishal, you can share it on your WhatsApp group, or those of you who have not received it, you can send an email to us. Happy to share that with you. In Allo, thank you. In Allo Health, we do a screening call, which is a very brief 10 to 15 minute call where we get a broad overview of what the problem is. So that's a brief evaluation. We follow the DEO structure. A detailed evaluation form is the one that you will get in the Zoom link. So just a snippet of how it looks. Please feel free to use it, modify it to suit your needs. The basic socio-demographic details, general description of the problem. When did it start? How frequent is the sexual activity? The nature of the onset, duration. Sometimes this itself gives you a very clear clue what it is. I'll give you an example. The man who says, I'm married for the last 1 month. On the 28th day, I could not get a good erection. I have ED. I have gone to 4 urologists. I have done all the tests there are. So you know it. If it is a sudden onset or a rapid onset, if it's there only for a short time, you can reasonably conclude that it is not a hardware problem. Probably it is a software issue. It's a performance anxiety. So you evaluate, you counsel him. You may want to give him a PDE5 inhibitor just to help him get that confidence. So taking a detailed history saves a lot of, the patient's misery. So background issues or contextual factors, we want to know his previous experience, other comorbid conditions which can contribute, substance use, as was asked by somebody in the chat window. You also want to get a little history about his relationship, how long is it, how committed they are, what is going on, etc. Then we move on to specific history, which is following the DOR model. As you will see here, the female sexual history. A simple way to ask it would be, the lady says the last few months she's not enjoying sexual activity. So you want to ask if she has desire to want to be intimate. Has it changed in the last few months ever since this problem started? Then excitement, which is arousal. We ask around questions around the ability for her to feel aroused. What I forgot to mention in the Dior model was men get excited very quickly. Men are very visual. If they fantasize, if they visualize, they are able to get aroused. Women, on the other hand, need more touch. So do they engage in adequate foreplay, at least for about 5-10 minutes or more? And then asking them about whether they feel wet, getting lubricated or not. Question around orgasm, if there is any pain, do they achieve it, etc. In men, the same desire question, excitement around questions around erection, as I described previously, ability to reach climax. If yes, what is the average duration they take to reach there? In Allo, we are a digital company, so a lot of the work happens online. So patients fill a form that takes about 3 or 4 minutes. At the end of it, this is how the form looks, constructed around the Dior model. And then this is an output that the doctor gets. So even before I have seen the patient, I broadly know what is the problem. Is the issue with desire? Is the issue with erection? Where can I focus my questioning? So this has made life a lot easier for all the doctors who work here, because technology helps us quite a bit. Physical examination, there are some dilemmas. Should we be doing it in all cases? Should we be selective? If you're following a teleconsultation platform, then how do you go about doing it? Should it be a partial genital examination? Should it be a full body examination? Who should be doing the examination? Should it be you as a psychiatrist? Or should it be a specialist like a urologist or a gynecologist? So here's what is helpful. In an otherwise fit and well young man, by young, we are looking at somebody under 40. Often, if the history is in a telltale, more on the psychological domain than on the physical domain, you can possibly avoid medical examination, intimate physical examination. I mean, focused blood test perhaps may be necessary. If also there is a condition specific, if a man is complaining of pain during intercourse, if he is not certain that he can pull the foreskin back, or if the lady complains of pain during intercourse, I, for one, encourage them to see a local doctor before we assume that it is a vaginismus or sensitive glans penis. Though I'm a medical doctor like all of you, I have lost the skills of examination, so I do not examine, genital examinations. General physical examination, where it is necessary, of course, I do it like any psychiatrist would do. Important to get a physical examination on a case-by-case basis, because it gives you clarity about diagnosis. Patients feel reassured. You can educate the patient. So you need to take a call on that. Okay, we've done the basics. We've done the approach to history taking. Now I'm going to focus on treating sexual problems. This is, perhaps the last part of my talk. We'll talk a little bit about career options for young career psychiatrists. I've divided this section into two, one on general approaches and secondly on specific approaches for some common conditions. Okay, a quick history. So psychoanalytic approach used to play a dominant role, starting with Sigmund Freud, continuing till the mid 1900s. The focus there was more on deep-seated issues, early childhood experiences. Freud has been criticized for taking this approach a little too far. Masters and Johnson, a couple who came together, did some wonderful experiments. They laid a lot of emphasis on physiology. They came up with their own therapies, and they are truly the pioneers of modern sexual medicine. I was lucky to be trained by somebody who was trained by them. And you will learn and make modifications as I have done to suit our patient population. Today, sexology, the word has medical and non-medical aspects to it. By medical, I mean use of devices, use of medications, and non-medical would be therapy. I don't know whether you'll be disappointed if I tell you that sexual pharmacology
I think your screen is
prohibitive.
frozen.
Then you
Yeah, please.
have a bunch of SSRIs and depoxetine for premature ejaculation. Barring these, you don't have too many drugs to play with. So a combination of medical and non-medical approach is what yields results. So Plicit model is something that you should all know about. I'll go to the next slide, which will give you a clear picture. P is permission giving, LI is limited information, SS is specific suggestion, and IT is intensive therapy. So even with limited training or with your own personal interest, you can very easily master the first two levels. We at Allo do something called as the Allo Training Academy, training for mental health professionals, which will get you up to level 3, which is specific treatments for some conditions. If you want to do intensive therapy, I'm afraid you'll have to join Allo, work with Allo, or enroll for courses which are full-time, like the ones that I did. So permission giving is as simple as telling your patient who has concerns about masturbation that it is safe, it is healthy. What is not okay is compulsive masturbation, where a person does it for the sake of doing it because he is not able to sleep, or many people use masturbation as a way to relieve stress. So that is all it requires to allay their fears and anxieties. Limited information would be maybe explaining the anatomy, telling them that it is okay for them to feel a little discomfort if it is a man the first few times that he tries to have intercourse, because when the foreskin is pulled back, there is sensitivity of the glands. To explain to a woman the importance of foreplay, or giving herself the time in which she can get ready, lubricated, so that there is no pain or discomfort. Specific suggestion would be teaching techniques, for example, the stop-start technique, giving medications like sildenafil, tadalafil with specific instructions. Intense therapy is for the couple who have not been able to consummate, or the man who has extreme anxiety. Okay, so sexual therapy currently involves the use of multiple domains. There are a few new that got added. For example, mindfulness is also on that list, devices, etc. But it's a mixture of a few blends of modern therapy techniques. Psychodynamic does have a role on a case-by-case basis. We have developed something called as the Allo MIST model, the multi-integrated sex therapy, as we call it, where we have medical doctors who do medical consultations on the Allo platform. We have psychologists who offer therapies. We have medications. I'll just show you. Yeah. So we have um, tasks that are given. So using a stepped care approach, we have found that the results are pretty good. So common issues. Yeah, I've taken a few common vignettes from the erectile dysfunction, complaint. Let's say a 25-year-old man who worries about not getting good erections during masturbation. He's never had a partner, he's never attempted sex, but he's concerned. Or a 28-year-old guy in a relationship who suddenly finds that he's lost erection with his partner. After that, without giving her any reasons, he stopped, getting close to her. Take the case of a 55-year-old married man who complains of losing erection and desire in the last 1 year, both during masturbation and sexual intercourse. So the approach is going to be different for all these three. What we have done in Allo, because there are about 50 odd people who work for Allo Health, we have a wonderful tech team. We have used what is called as the DSS. Decision support system is what it is called. So we go through an algorithm which we have developed, taking in consideration the major sexual health guidelines that exist across the globe, and made the doctor's job a lot easier, because the decision support system tells us what is the likely way to approach a patient in any of these categories. Of course, the doctor can override the AI-supported system. Broad medication approach and non-medication, of course. If there are reversible causes, we would say, let's identify those and try to see if they make a difference. A person who smokes heavily, we offer him nicotine cessation. The 55-year-old man, we want to evaluate and see if he has problems with his sex hormone profile. So we would get measurement of his testosterone, SHBG, prolactin, LH, FSH. Just as a quick tip, if you're asking for blood tests, please get them done before 10:30 a.m. After 10:30 in the morning, the levels of testosterone drop. So often people get false results and they get worried. If they're on medications like antidepressants, some of the antihypertensive, some of the antacids can also cause erectile dysfunction. We have a long list of medications that can contribute to it. If any of you are interested, let us know. We'll send it to you. First line medication therapies, we use PDE5 inhibitors. They are revolutionary. When they were introduced in early 2000, it was thought that there was no need for any kind of counselors, therapists, or any other disciplines. Lo and behold, we have about 50-60% of patients who have failed a trial of PDE5 inhibitors. Then there are the vacuum constriction devices. The uptake is not great because there is a break from foreplay and intimacy. They have to use the device. It takes some discipline to learn how to use it, etc. So generally works well in settled couples, in the elderly gentlemen. Second line therapies, I wouldn't advise any of us in this group to use these, because they are preferably used by urologists, which include injections or some medicines which are directly introduced into the urethra. Third line, of course, is not for us. It is definitely for urologists. Because we do use and can use, just a little overview. Sildenafil takes about half an hour to an hour, works for about 6 to 8 hours. Tadalafil, the advantage is works much faster, does not interfere with food, the pharmacokinetics. The big advantage of tadalafil is it's a long-acting drug, works for about 24 to 48 hours. Some people call it as the weekend drug. He takes it on a Friday when he goes to visit his girlfriend, and he's happy till Monday morning sometimes. Vardenafil is available now in India, pretty similar. If one doesn't work, we switch to the other. But in general, the advice is take it 1 hour before. There are two ways to use PDE5 inhibitors. The on-demand use, the SOS use, you can use all the drugs, or the everyday use. For that, the license currently in the Western countries is for tadalafil. So low dose tadalafil, 2.5 mg to 10 mg, is used on an everyday basis. I'll tell you more when I show you the tadalafil slide. Sildenafil, the dose is between 25 to 100 mg. Headache is a problem. So you have to explain it to your patient and say, if you do get a headache, which is tolerable, don't worry, it goes away in a few hours. If it becomes too much, then take a paracetamol, 500 or 650, whatever you have. Nitrates is definitely a contraindication, causes precipitous drop in blood pressure. There have been reports of deaths. So when you take history, please ask for history of angina and whether they are on GTN sprays or use of nitrates in any form. Tadalafil, like I mentioned previously, can be given as an everyday drug also, 2.5 to 5 mg every day, and on demand the dose is between 10 to 20 mg. 2.5 mg, very few companies have it in India. 5 mg is available. This also causes headache. Back pain is a peculiar problem, but the incidence of headache are less compared to sildenafil. Has a longer window of opportunity. So to get the best response, you need to, prep your patient well. Don't just go by the history where he says, हाँ ये ड्रग तो मैंने यूज कर लिया है, मेरा दोस्त बंटी है उसने दे दिया था. So you'll hear a lot of stories. Don't just jump the hoop and dismiss those drugs. Ask him, did he give a gap of at least an hour before trying? Did he give enough time and have foreplay? So the way I explain when I prescribe this is, talk to your partner, ask them if they are interested in engaging in intimacy, take the medicine, give a gap of at least an hour, engage in foreplay at least for about 10 minutes or more. And with sildenafil, you have a window of up to 6 to 8 hours. With tadalafil, you have a window which is much wider, and anytime you try, you should be able to get the support from the medicine. Where that this is largely performance anxiety or software, as I call it, the unwritten rule is start high, come low. So if it is sildenafil, start at 100 mg, tell him that next time he should try with 100 mg and then subsequently try 50 mg, 25 mg. With tadalafil, tell him to go up to 20 mg first and then reduce the dose. If you know that the anxiety is going to be persistent, if you know that he's very worried, and they try at least once or twice a week or a few times in a month, give him everyday low dose. And on top of it, he is okay to take a SOS tadalafil 10 to 20 or sildenafil 50 to 100. Okay, so that's the tadalafil, that's the erectile dysfunction approach. So the young 25-year-old, I would probably push him more into seeking therapy, explaining the normal physiology. The 28-year-old, I would give him an SOS medication. The 55-year-old, I would probably evaluate him, get him evaluated by a physician, by a cardiologist, get his sex hormone profile done, and then possibly consider giving either everyday tadalafil low dose or give him a SOS medication if necessary. Of course, education and counseling goes to all of them without doubt. Premature ejaculation, let's think of the common scenarios here. You do get a young guy who has tried having sex for the first time and thinks he has PE, or a 32-year-old man in a long-distance relationship. Yeah, I was talking to somebody in Pune. I was saying this is the Pune-Bombay couple. I'm talking to people in Delhi. I don't know, this is Delhi Varanasi or Delhi, yeah, some other neighboring Delhi Chandigarh couple. So weekend he goes to meet her and he has issues when he meets her with early ejaculation. Or the 38-year-old man with 2 children, he's very dissatisfied now because he's ejaculating in 30 seconds during sex. That should give you a clue that ability to hold longer is not a necessity for fertility. I do get men who say they ejaculate in 30 seconds and they're very dissatisfied, but they have been able to successfully go ahead with pregnancy. So how do we approach these people then? This is the ISSM, International Society for Sexual Medicine approach. So it's a little busy slide, but I'll quickly take you through it. We take a detailed history, reassure, educate. Then if it is indeed premature ejaculation, we look if there is another dysfunction, because you can have 2 things coexisting. You can have ED with PE. Then you have to also decide whether this is primary or secondary. So has this happened lifelong, as is the case with the third gentleman, or is it an acquired PE? He was fine till his wife got pregnant, and then after a gap during pregnancy and postpartum period, he starts experiencing. So what is the approach to these people? We combine pharmacotherapy, we do education, and sometimes we do combination treatments. Focusing specifically on medications, we have only SSRIs and Depoxetine. Depoxetine is the only drug that has a license. Otherwise, use of SSRIs is off license, off label, and it is okay to use them. You won't get into trouble, for using these. So if you look at the data, the ISSM data seems to indicate the best response for paroxetine. There is an 8-fold increase, they say, but no, we don't often get this kind of a response. So paroxetine sits on top, Depoxetine somewhere in the middle. We have clomipramine because it is a serotogenic drug, as you would all know, and all the other SSRIs come down there. There is another option, which is the use of local anesthetic gels. Earlier, lignocaine was the only one available, whereas now you have a combination of lignocaine and prilocaine. The advantage of this is one works faster, the other works longer. So the brand names are Prilox, Primla. So if you are going to recommend the use of medications, then you have 2 options here. You can advise everyday use. How we have devised our DSS is in Allo is anyone who is sexually active at least 2 or 3 times in a month or more, we give a course of, let's say, paroxetine or sertraline, a dose, that is typically on the lower end. We have generally used longer-acting paroxetine, sustained release preparation, so a 12.5 mg or a 25 mg titrated dose every day for a month. Depoxetine cannot and is not licensed to be used every day. Please remember that. You can use SSRIs, clomipramine or depoxetine as an SOS drug. An hour before they want to have sex, they are advised to take one tablet. The use of local anesthetic gel, the man is encouraged to pull the foreskin back, apply a pea-sized amount of the local anesthetic gel on the tip, pull the foreskin back, leave about half an hour. If a man is circumcised, then he applies on the tip of the penis, but he has to wait at least for about 45 minutes to an hour, takes longer in circumcised men. Wash the area with water and then proceed with sexual intercourse. Okay, there is the stop-start technique, also called as edging. We have created a video, so the video link is sent to the patient from Allo. They look at it, they learn it, they practice it. Essentially, it is a man who learns to delay his ejaculatory inevitability. Okay, so that is what is done. Just a quick overview before I conclude about what is done in the therapy setting, the intense therapy or the specific suggestions. So Masters and Johnson, they quickly understood that anxiety and stress plays a huge part. It is no longer fun, it becomes work. So they introduced tenets of communication, relaxation. They essentially used approaches that you would now call as systematic desensitization or a graded approach. So they called their treatment as sensate focus. Now it is called by some people as sensual discovery. Initially, the couple who have tried and end up blaming themselves or each other is encouraged to not worry about the penetrative act, to only focus on non-genital pleasuring. So it is done in a systematic manner. Please don't make a half-hearted attempt because couples who have tried and they say this doesn't work are not open to trying it when they go to a specialist. The next stage is genital pleasuring. So they are encouraged to explore the genital areas, but in stage 2, there is no penetrative sex. Stage 3, if it is a lady who has vaginismus, we encourage her to hold the penis, guide it inside. And initially, there is no thrusting till she is comfortable and ready. Only when she is comfortable and ready, they go ahead with the thrusting that is encouraged. Okay, so let's talk about common female sexual dysfunction that we see. Let's say this is a lady who is 28 years old. Her partner is 30. They have known each other for about 4 years. They got married last year. They come to you and say, they have not been able to consummate the marriage. By the way, to me, this is a very unique problem to the Indian subcontinent, because we see a lot of couples who have been together for many years. I've even seen couples who have been married for about 18 years. They have not been able to consummate their marriage. It's a very sad story, because they tend to live in the silos of their own misery. They are very uncomfortable talking about it. They don't know who to go to. A colleague of mine, he says unconsummated marriage is an emergency. Please treat them ASAP. So this lady was earlier very reluctant for any sexual intimacy. After much persuasion by him, that took about 2 years in their courtship. She was okay for foreplay, but she would complain of pain during any attempt to engage in intercourse. So they agreed mutually that maybe they should try this after marriage. Now, even after a year of marriage, this hasn't happened, and they have lost interest. Later on, it turned out that she has gone through some sexual abuse as a teenager, and her expectation was that it is going to be extremely painful. So a couple who comes to us like this, we explain to them that unconsummated marriage happens because of three reasons: her causes, his causes, or mixed, combined, unknown causes. A detailed history, and then if it turns out the problem is typically vaginismus, and we often encourage her to have an evaluation by a gynecologist. See, what happens there is any attempt at penetration leads to a negative experience. She ends up getting a lot of anxious cognitions, catastrophic thoughts. This whole fear creates a sense of hypervigilance. She becomes a spectator. Either she avoids, and often it leads to more tension in the pelvic floor muscles, followed by the whole cycle repeating itself. So the approaches involve education, telling her and him about anatomy, explaining about the pelvic floor, teaching her Kegel's exercises. There is a wonderful questionnaire called VPCQ, Vaginal Pain Cognition Questionnaire. It yields a lots of myths and misconceptions that she may have. There is a vaginal trainer. There it is. Never call it as a dilator because there is nothing to dilate. The vagina is not a hole, we say in our therapy sessions. It's an opening. So women are taught to use their own fingers to generally get comfortable with finger insertion. So this is something that is taught to them systematically by the therapists from our team. Then use of lubricant, sometimes local anesthetics. Often we notice that there are other secondary anxiety disorders. They have other phobias as well. So we may need to resort to treating it with anti-anxiety drugs, couple therapy. There's some research with use of Botox injections. I'm not trained, I wouldn't advocate, but it's there. Some specialists use it. Sometimes there is a overlap. Devil is in the detail. So desire difficulties can be because of vaginismus. So lady who has vaginismus, she's not able to reach orgasm. She experiences a lot of pain. She doesn't get aroused. She loses desire. So a detailed history will yield a lot of information for you. Okay, the last few slides before I stop and take up questions. Sexual medicine, unfortunately, is still not a recognized specialty in its own right. Now, do you see it as an opportunity, or do you feel that it's a curse? I definitely see it as an opportunity. It puts you in the front running sort of capability because you already have the skill set of history taking, getting into nuances, making patients comfortable. Teleconsultation, after it became legal, during COVID times, has made it a lot easier because these are people who are not comfortable going and seeing patients. Don't be surprised if I tell you Allo celebrated its anniversary last week, and we have seen close to 10,000 patients. Digital healthcare space is rapidly expanding. The best part of sexual medicine is the therapies are very brief and dynamic. You see results in 4 to 6 sessions. The missing piece of the puzzle is training. So somebody asked me early on in this talk about where to get trained. In India, to my knowledge, there's only one recognized training specialty, training center, which is JSS Mysore, who have university recognized training. Those of you who are very interested, there is a crash course by the ESSM, European Society for Sexual Medicine. It used to be called as the Oxford School of Medicine, which was very popular when I was in the UK. Now the ESSM has a training which is a crash course. I think it's morning 8 to evening 8 for 10 days. There is an exam. You have to make one more trip to Europe to give that exam, and you get a degree, which is the fellowship degree. There's no hands-on training in that course, though. See, nothing stops you in India from practicing as a sexologist. You, as a mental health professional, can easily practice. Now, I don't know how much valuable the training course is, but certainly if you are interested, you must. We started our venture about 3 months ago well, Allo has been in existence for a year, but the certificate course, we did a pilot program, and we said that we are also going to focus our interest in this. There are 3 things Allo does: clinical consultations, education, and education to the lay public and patients. We are quite heavy on that. There are a lot of educational videos. There are blogs that are on the platform, because we strongly believe that our country, which does not currently allow sexuality and relationship education for young people in schools and colleges, it's a duty that we have to train and educate. So that's another domain. The third one is to train doctors and psychologists. So that is part of what we do. We have a faculty. I'm the lead for it. We are also coming up with a course for MBBS doctors. And it's a structured modular training. There are live sessions, there are quizzes. We have created different modules. We have a skills corner where we have recorded, for example, the skills of how to explain stop-start technique, how to explain, let's say, sensate focus to a couple. We did a pilot program. We had about 17 mental health professionals, 14 psychiatrists, 3 psychologists. We had guest lectures, and we are quite buoyed by the idea of this program. What we now want to do is we are in talks with some universities to get accreditation. We want to also include an element of hands-on training. So there will be an internship wherein people can work remotely, see cases. So lots of things that we are hoping to do. I will stop my screen share, answer some of the questions that have come here, and probably hand it back to the chairpersons after that. So quickly going through the questions that have come. PDE5 inhibitors not tolerable due to side effects. How do we progress? So as you would have noticed, we have a holistic, the MIST model approach. So medications are only one part of the treatment, but we do often get people who say they have headaches. We resort to using low-dose tadalafil. But even if that doesn't work, we switch from one PDE5 inhibitor to the other. We now have avanafil also available. But if nothing seems to be working, I'm afraid you hit a dead end. But I don't think we see many patients where we reach that dead end. Fellowships and diplomas, I have answered. SOS.
Let me help you. Dr. Sandip, let me help you. Okay. There is one question: SOS PDE5 versus a night low dose, which is preferred?
Yes, sir. Yes,
another question.
So I will, I covered that in the talk earlier. I'll just highlight again. So if it is a couple who are sexually active early in their relationship, or if it is somebody who is, let's say, beyond 45 or 50, but still sexually active, multiple times in a month, everyday use is not a bad idea. For the first example, we would initially use it every day for a month, and then taper it off and stop and only make it available as an SOS. For a couple who have intimacy intermittently, the Delhi Chandigarh wala couple, we would only give him SOS medication there. So you have the liberty of trying to switch between either of these options.
Newer treatment drugs for the ED?
Nothing new has come in the market as far as I know. Another PDE5 has got added, Tentex Royal. I think this is a herbal drug. I don't prescribe. Yes.
This is very long.
Tentex Fort was something I had heard of. Royal must be a combination.
This is like when I joined SR ship in Delhi after Manipal. So it's very long. It's another old drug.
Right.
But it is a herbal drug. It's Ayurvedic.
Newer advances did happen in the field of female sexual dysfunctions. There was a huge lobby with the US FDA by the women, because I don't think research has done justice, because everything that you currently have is only catering to the male sexual dysfunction. There was nothing. So 2 drugs came. They have not gained popularity in the US. I don't think they are coming to India. One of them is a subcutaneous injection, which women have to improve their desire. So women said, why am I going to inject myself for him to have better sex with me? So no, we don't have medications there. Bupropion is a strange drug, helps you when you have sexual dysfunction with other medications. Yeah, since many of you are psychiatrists, the 3 top drugs that seem to come up in your PubMed search, which have low propensity for sexual dysfunction, are bupropion, venlafaxine, desvenlafaxine, and now
also metazapine.
Metazapine also, but it again...
Vortioxetine.
Vortioxetine, the manufacturer says is neutral, but on a case-by-case basis, I've had people complain, not trazodone, no. These 3, especially bupropion. Bupropion also, by virtue of its dopaminergic action, improves desire to some extent, but it is not an aphrodisiac. Off-label use of bupropion you can do because many of the treatment guidelines put it in low sexual desire, then delayed ejaculation, bupropion finds a mention, but the evidence is not very robust. Okay, Dr. Neha.
There's one role of yohimbine. Role of yohimbine and cyproheptadine in SSRI-induced sexual dysfunction.
Yes, sir. Cyproheptadine is a drug that we do use in delayed ejaculation only. Cyproheptadine is an anti-allergy drug. It is available as a 4 mg preparation. If you have a man with delayed ejaculation, you can try it a little like what you would give in premature ejaculation 1 hour before, as an SOS. But I have not found it to be extremely helpful. Yohimbine, no, sir, I don't find it very helpful. Side effects. These are generally second-line drugs.
L-arginine?
Okay. Nutraceuticals, slightly controversial because the pharma agent will come and rattle off a lot of brand names to you, whether it is L-arginine, L-tryptophan, or some horny goat extract. So then there is the Chinese herbs, etc., etc.
Also,
they are not first-line drugs, but they do have a place if you believe in them as an add-on drug. L-arginine probably is a front runner. but make sure you are giving at least 500 milligrams or more.
Okay.
L-arginine thought to improve blood flow, especially to the penis for men, but don't overemphasize it is all I can say. You need to get to the bottom of what is the problem, try to treat. May have a placebo role also. There are studies to say that they do increase endorphins and endogenous testosterone, etc. But the evidence is not robust, not as robust as PDE5 inhibitor in erectile dysfunction.
There's another question about apomorphine.
Yeah.
Same, sir. I would put apomorphine, yohimbine in the same category, I would say, sir.
Okay. Two female psychiatrists asking, two questions related. It is treatment options for reduced sexual arousal in females, and also about the treatment anorgasmia in females.
Okay. If I hear it right, to reduce sexual arousal.
Treatment for reduced sexual arousal.
Sorry.
And treatment for anorgasmia.
Anorgasmia.
Both is for females.
Okay, got it. Sorry, I'll request Dr. Vishal also to share our leaflet on, I think, just a sample.
On premature ejaculation.
Sample, yes, sample P leaflet. Feel free to download and use it. Also, I'm sorry, I'm doing a little more advertising for Allo because I truly believe that those of you who are interested, you should continue your learning. This week, we are starting something called as Learn with Allo. It's a WhatsApp group. I request Dr. Vishal to forward that link. You click on the link, join the group. If you're interested, you can join our twice a month webinars, etc. outside of this. Back to female sexual dysfunction. Female sexual arousal, no, there are no medications which have a very strong evidence base. We dig into what is the cause. The common causes are inadequate foreplay, low sexual desire, being on a medication like an SSRI, then women who tend to use these hygiene products. It's become very common for women to use vaginal hygiene products. Can I name some? Fem, V-wash, I-wash, etc. These end up causing dryness of the vaginal area. So more of education focusing on these things, helping a woman to identify what she likes and teaching the couple to engage in those is thought to be more helpful. Again, bupropion, worth a try, 150 to 300 milligrams daily. With regards to climax or orgasm, it is also an extension of what we discuss in the female arousal. But I've had women, despite having a partner, despite adequate foreplay, not being able to reach orgasm. So we reach a dead end. There is a device called as Eros, Eros clitoral device, CTD, available on, imported and available on many of the platforms in India. It has a little cup, much like a vacuum device for men. And through a pumping action, blood flows into the clitoris and gets a woman to reach climax. Any other questions?
Yeah, there's one. Have you ever encountered PDE5 dependence in your practice?
Very good question. Does not cause physical dependence, but psychological dependence, yes. I have seen quite a few men who swear by it and who say, if I take it, I'm fine. I mean, there was a funny one where the guy said, as long as I keep it in my pocket, sir, it works. ये एक Wi-Fi के जैसे है, remotely Bluetooth, I don't know what it is, but as long as I have it, it works. So yes, they have developed a sort of psychological dependence. So educating, weaning it off, helping them realize that probably it works on the software rather on the hardware in their case, has helped to get off them. Related question to this, nobody has asked. Is there a limit to how long these can be prescribed? Actually, there is no limit. If it is a case where it is a hardware issue, the man can continue to take it indefinitely as an SOS drug, of course. So yeah, they can't get dependent.
2 more questions, and then probably we'll try and close it now. There are 3 more now. The questions are increasing. Okay, so one question is how to manage a patient with nocturnal emissions, night falls.
Okay. This
and should I tell you the
particular
second
young
question?
man with nocturnal emission has gone to Hakims. He has gone to other people who have told him that it is a disease, and he will give him a lotion, a potion, caused a lot of commotion. So you have to take a step back and take the history, educate him. Sadly, there is no treatment. Please don't prescribe unless you think it has led to something like a Dhat syndrome, wherein you have to specify and say, look, it's mind to body, body to mind. Please read up Reattribution Therapy by Goldberg. Simple 3 steps. Okay. Understand, link, and change. So help him understand what is the problem, link his problem mind to body, stress to problem, help him change. So even if you're prescribing a medication, tell him that I'm not giving it for nightfall. I'm giving it because your stress of nightfall has affected, your physical functioning, etc.
Can I add to that? And I hope you don't mind.
Please do. Please do.
I think the other way out is we start in anti-anxiety, like an SSRI, paroxetine or fluoxetine for him. And once he settles down, then you tell him this, then he understands better. Otherwise, the person usually runs away from you.
Very true, very true. But no, the point I was making was even with SSRI, he may end up having a nightfall. If he is not sexually active, the way I explain nightfalls in 2 lines is, nightfall is the route that your mind and body are taking, because you are not sexually active, whether through masturbation or with a partner.
Right.
So yes, that's how it goes.
So that's.
You said one last question.
Actually there are two. Now there's one more actually which has come in. How to manage a case of paraphilia, especially pedophilia?
Okay, I'm getting all the difficult questions now.
And there's one more legal question after this. There's a legal question after it that Rashni has asked. So you're getting into difficult territory now.
And then Dr. Aditya is asking about flibanserin in sexual dysfunctions. That's an easy one to answer. Not yet come to India. And that's the drug I was talking about earlier, where it's not been found to be extremely helpful. So it's I'm told that it is losing its sheen even in the US, flibanserin. Pedophilia. Very tricky to treat. Firstly, they don't come to you by their own volition. Often they are dragged to you by their partners. So the engagement itself is not going to be great. On the odd occasion, I have had people who have come and said, look, I secretly dress up in my wife's clothing. I get a lot of high from it. What do I do? In the Western world, there is a separate group who treats them. And this is called as the Sex Offenders Treatment Program, SOTP. Because all of these guys often come to the notice of professionals through the legal route by the police and by the judiciary. So I am honestly not trained in this to a great degree. Not easy to treat. If you know somebody who practices forensic psychiatry, refer them on to them. In Bangalore, we are lucky to have Nimhans in our backyard, so they get them. Even they struggle, is what I am told. Not easy to treat. I mean, I can send you articles on how they are managed. There is the option of anti-androgens, etc. But I would encourage you not to get into it, please, because it requires monitoring. Now, with the POXO Act, you are mandated to report if you come to know that there is someone who is, soliciting or having sexual activity or even showing sexually explicit material to under 18s, an offense. So always have a phone a friendly lawyer on your speed dial and make sure you get the right information. I think we'll stop there because it's lunchtime for all of you.
Yeah.
1 o'clock.
You just one, just no, this is an important question.
Oh, yes, go on, go on.
He's a very senior. Yeah, one just. Last, this will be last question. Sometimes there's a demand from newly married young man to be declared not impotent after medical examination.
Okay. No, this
Can a
is
protocol be followed?
what protocol do you follow? Thankfully, the whole test of impotence, etc., is done by urologists. I have had a couple of requests. One from the family court saying, "Can you tell us if this marriage was consummated, not consummated?" Now, I gave a testimony based on the history that I was given, but invariably they will go to andrologist or a urologist who will do a penile Doppler, use bi-mix, trimix injections on the penis to see whether the blood flow is there or not there. But be careful before you write and give. If there is a request, you can say, I will respond to it once I get a formal written request from your lawyer. And in the format or in the report, make sure you give factual details and not conclusive details, and end with a note saying definitive yes or no. For impotence is a legal term, again, it's not a medical term. Often impotence is meant to indicate erectile dysfunction. So try and use medical terms, but indicate that definite diagnosis is only through a test by a urologist. However, if a judge or a court summons you and says, come and give evidence, there's no escaping, you have to go there.
Thank you. Thank you very much. If you have patience for one more last question, I don't know. That'll be purely last.
Yep.
So there's what Dr. Manoj asked, status on normal range of IVELT in Indian population.
IVELT, for those of you who don't remember, is intravaginal ejaculatory latency time, how long a man lasts during intercourse. There was a famous study done across 11 countries, 1,000 men in each country. They were given a stopwatch, start when they penetrate, stop when they ejaculate. We don't have definitive data for India, but global data is 2 to 5 minutes. There is a debate on whether less than 1 minute should be called premature ejaculation or less than 2 minutes. DSM-5 says less than 1 minute after penetration. And then the European guidelines, ISSM, they all say less than 3 minutes. In allo, we go with less than 2 minutes as the definition, all the time or most of the time, with distress either to one partner or both. Yeah.
Okay. Thank you so much. It was very exhaustive and very interesting talk.
Thank you. Thank you.
Very nice, Sandip.
Thoroughly enjoyed, and thank you for the participation. We'll send a feedback form to you. Kindly fill it in your own time. It helps us. So yeah, if you can disseminate that, Dr. Vishal, it'll be helpful.
I hope so, because I think I see in this group, there are not only people from Delhi, but all over India. I don't know where all the pictures are from.
Okay.
So we'll try and so anyways, people who are out of Delhi, please message me on WhatsApp number. I'll tell you my WhatsApp number right away. It's 9891055258. I'll also put it on the chat with my name, so that people who are not in DPS group, they can message me, because so that I can share the link also of the recording later with them.
I've shared the link to the WhatsApp group. If you want to learn with Allo, please click on that, join us.
I've already done that. Yeah, I've done that.
Okay.
You also done it?
Yeah.
Yeah, you can do that. I've also put it also on the group, in the chat. I've also put the history taking format which you shared. And I've also put this, so I already put a couple of things there. So Dr. Pankaj.
Yeah, hi. Dr. Sandip, thanks for such an elaborate presentation. It's a sign of a very good presenter to make difficult things sound easy. So it was a difficult topic, and I know there is so many take-home messages, DOER, devil in details, placid. Then the special investigation things like testosterone testing should be done before 10 a.m. And the prescription thing that no fat meals with the PD5. I think PGs and young psychiatrists will be more benefited with such information. And it was very nice learning with you, sir. So I hope you will be available to us even in future. And I would like to thank Dr. Vishal and Dr. Manushi for bringing up such a good topic, which we usually miss. So another thing is that my co-chair had some important work, so he left. Wishing you all the best and thanking you for very nice presentation. Thanks, Dr. Sandeep. And over to you, Dr. Vishal.
Thank you, Dr. Pankaj. Thank you so much. Thank you for sharing and being there throughout. Thank you, Sandeep. And now with Sandeep, hopefully, Sandeep, as we discussed, we will try and roll out a certificate course for the DPS members on psychosexual health or sexual health. And we'll hopefully come up with details. Also, people who are joining in today, remember next month also we're bringing another interesting topic. That next month will be psychedelics in psychiatry, another interesting, not talked about topic. And we'll probably be using on the second Sunday of next month. Also, we request PGs who are there and SRs who are there, please do present your cases. There's a slot available this month, last Sunday, for the case history discussion. Please do that here. Do let Dr. Manushi, Dr. Pankaj, or Dr. Paramjeet or me know that you're interested, and we'll put you up. And you remember, we do give certificate for the same in our annual conference, so we'll do that. Dr. Sandeep, the question he asked was basically same which you are. Is Shilajit effective in sexual disorders? Dr. Rohit asked.
Okay. Yeah, so
I think which you tangentially did answer.
We are practitioners of modern medicine. Better to stay away from herbs and not get into trouble for prescribing them. Yeah.
So I think you did answer tangentially when you said all these are not very effective. If it was, we would be all using it. I think, yeah, we should do that. So thank you, Dr. Sandeep, and thank you everyone for joining. I will be closing the recording now, and I'll be uploading it later and share it in the group. And for people who are not in DPS group, do message me on the number I've sent. Thank you, everyone. Thank you. Bye-bye.
Thank you. And thank you, the chairperson for today, Dr. Pankaj and Dr. Kataria.
Thank you.
Thank you.
Thank you, sir.
Dr. Manushi. Thank you, dear. Bye.
Bye-bye.